Hello, this is the second part of the video lecture on thyroid cytology and pathology, and this is primarily aimed at surgeons as well as surgical residents so that you can better understand how it is that we make our diagnosis. In the previous talk, I focused on thyroid nodules. Now I'm going to look at thyroid cytology. So we're going to look at some technical notes in terms of adequacy, specimen triage, and processing. And then after that, we will look at some diagnostic aspects, specifically looking at the Bethesda system for reporting thyroid cytopathology, and just very briefly looking at a few cases. So ROSE stands for Rapid On-Site Evaluation, and this is usually attended by the cytotechnologist, sometimes also by the cytopathologist. And I'm referring to conventional cytology here as opposed to liquid-based cytology, where the needle material is rinsed in preservative and sent straight to the cytology lab. For ROSE, the cytotechnologist actually attends the procedure. The main aim is to evaluate specimen adequacy to tell the procedurist that they have enough material and that they can stop. The other aim is to perform specimen triage, and this is very important to maximize the specimen yield at the time of the procedure. Let me just quickly show you some of the equipment that we typically have on our ROSE trolley. Of course, we have the microscope here, we have the staining solutions, and we have these specimen collection bottles. This is sterile saline, this is an empty bottle, this is RPMI solution for flow cytometry. Looking at the fixatives and the stains, we have two main types of smears, alcohol fixed and air dried. The alcohol fixed smears are stained with the pepper Nicolau stain, but they are not evaluated for ROSE, mainly because the pepper Nicolau stain takes too many steps and it takes a bit too long. So typically when an FNA pass is done, the needle contents is expelled and two smears are made for each pass. One smear is put straight into 95% alcohol and this is left alone and brought back to the lab. The other smear is dried in air and then it is stained with the Romanowski type stains, an example of which here is the Hemacolor stain. And this is a very quick stain. The entire process takes about a minute or so, and this is what we do for rapid on-site evaluation. So it is very important to note that we are only looking at some of the material that has been aspirated and not all the material. Hence, there is a potential sampling error and there's room for discrepancy in the immediate provisional assessment compared to the final assessment. Now, in terms of specimen triage, there are many things that we can do with the needle washing or with the neat aspirated fluid. One thing is that we can actually spin, centrifuge the material and stain it and concentrate the cells to look at them. We can also create or process a cell block, and this is like a mini biopsy from needle rinse material, and this is very, very useful because we can do lots of ancillary tests, including immunohistochemistry and molecular tests. We can, of course, send material to the microbiology lab for smears and culture, and material can be collected in this RPMI solution to be sent to the hematology lab for flow cytometry if lymphoma is suspected. And also, material can be sent to the biochemistry lab, for example, if there is suspicion of a parathyroid lesion. For a cell block, when do we want to do it for thyroid FNA? Generally, if we suspect something a bit unusual like medullary carcinoma or less common neoplasms, including hyalinizing trabecular tumor that I talked about briefly earlier, metastases, lymphoma, or we suspect a parathyroid lesion. Here is a cell block of a case which we suspected medullary carcinoma, and indeed calcitonin is positive. So it's very useful because with the benefit of calcitonin stain, we can give a definitive malignant diagnosis of medullary carcinoma on cytology. Now, for the smearing and the staining, it is important to sort of get the smear technique right, and we always hope for this beautiful lentiform kind of shape to evenly spread the cells. Every smear must be fixed immediately. So whether it is air dried or alcohol fixed, there has to be no delay in fixation. The staining is also an important part of specimen processing because too heavy or too light staining can also affect interpretation. Here is an example of an alcohol fixed smear with a Papa Nicolau stain, and this unfortunately was delayed in terms of the fixation. So a few seconds is enough to cause this marked artifact of swelling in the cells. So despite the fact that there is lesional tissue, it is actually a non-diagnostic smear because we cannot evaluate the cells. This is a comparison with a well-fixed smear. Again, this is alcohol-fixed stain with Papa Nicolau stain, and we can see the nuclear chromatin very crisply preserved here. So it is advisable to fix these smears immediately in alcohol without delay. Now, I just want to quickly mention the two different stains that we do. This air-dried smear in the Hemocolor or Romanowski type stains. This is very good for cytoplasm and is also good for stroma, mucin, background material like colloid. However, when the cells are dried in air, they will swell up. So we can think of this as a fried egg. For the alcohol-fixed smears, because the smears and the cells are immediately fixed, they have no time to swell up, and so the cells are always smaller. This is stained with a Papa Nicolau stain, and this stain is excellent for nuclear detail. So we can see that the stains serve different purposes, and because the cells do not swell, they are smaller, and therefore we can think of them in terms of a boiled egg. Now, there are some common misconceptions that I would like to help to clear up. One is that a larger needle gauge gives you more material. That is not necessarily true, especially in the context of a thyroid, because the thyroid gland is very vascular. So you would definitely get more blood using a larger needle. So the cytopathologists tend to favor smaller needles. 23 gauge needles are also quite good and give pretty good yield. Larger needles can be used for aspirating cyst fluid. The other misconception is that when you aspirate, you have more yield. So again, what you get is actually a more bloody smear. So this is useful for perhaps more cystic or fibrotic lesions. And in general, a small gauge needle without aspiration is one of the best methods to use. Here is ultrasound gel. This is an artifact that can sometimes obscure cells if it's very thick, or even worse, be mistaken for pathology. The way to prevent this is very simple, just to wipe off excess ultrasound gel on the skin before the needle penetrates the skin. Here is another artifact. This is due to blood clotting in the needle itself. And this is like a needle cast of a blood clot, and they are called worms. The problem with worms is that the blood is very thick and often obscures all the lesional cells. So again, it renders them non-evaluable. The ideal duration to be spending inside a lump where the needle is in the lesion is less than 10 seconds, and this would prevent or minimize blood clots and worms. Now let's move on to some diagnostic aspects. And this is the Bethesda system for reporting thyroid cytology. This is a 2018 revision. And I've given you the categories with the risk of malignancy stated in the Bethesda system and the management. Now you notice that for risk of malignancy, I have two figures. The ones in yellow are the ones where NIFT-Ps are now removed from the malignant outcome group, whereas before 2016, they were included as malignancies. So the reduction in malignant outcome really depends on how often we actually diagnose things as NIFT-P. And interestingly, in Asia, the rate of diagnosis of NIFT-P is actually somewhat less than in the West. So my best advice is to actually know the rate in your own institution. So for the categories, we have non-diagnostic or unsatisfactory, and management is to repeat FNA under ultrasound guidance. And then we have the benign category. We have atypia of undetermined significance or follicular lesion of undetermined significance, 10 to 30% risk of malignancy, less with NIFT-P removed from the malignant category. Management is repeat FNA or to perform molecular testing, or to even consider lobectomy if molecular testing points to a neoplasm. And then we have suspicious for follicular neoplasm. 25 to 40% or 10 to 40% risk of malignancy. And again, the management is to consider molecular testing or to perform lobectomy. And then suspicious for malignancy with usually surgical management recommended. And of course, malignancy, usually again, surgical management. In terms of molecular testing, as I mentioned earlier on in the previous table, which Bethesda categories actually benefit from molecular testing? Generally, the categories of AUS FLAS or suspicious for follicular neoplasm. In the Bethesda system, the Afirma rule-out test is mentioned. This is a gene expression classifier, and it's useful because it has a high negative predictive value if the result is negative. However, if the result is positive, it may not be so specifically predictive for cancer. The usefulness of this test then is to know which cases can be followed up non-surgically with a negative result. The sensitivity is fairly low for molecular testing, so one has to remember that the genetic aberrations that we're looking for may be present in as low as only 20% or even less of some malignancies. And again, as I mentioned earlier, the specificity for follicular neoplasms is limited because they have overlapping molecular aberrations between benign and malignant follicular neoplasms. Of course, one must also consider the cost. Here are some examples of commercially available tests: Afirma, Gene Expression Classifier, ThyGenX, and Thyrostick, and you can see that the cost is quite significant. So one must balance the cost with the cost-benefit ratio of a repeat FNA, in which most instances would have a more definitive diagnosis anyway. Now, I want to show you very, very quickly a little bit on thyroid cytomorphology, a little crash course, what makes a pathologist worried and what reassures a pathologist. So we'll look at architecture. So benign architecture typically is seen in the form of flat honeycomb sheets, such as you see here, where the nuclei are very evenly spaced out. These likely come from macrofollicular structures. When we see microfollicles and trabeculae, we are then a little bit worried, and this will come under atypical architectural features. Here is an example of a microfollicle, and also if we see nuclear crowding, and of course, full-blown papillary structures. Now, when it comes to the nuclear features, of course, the atypical nuclear features are all those that make us think of PTC, pale chromatin, grooves, inclusions, or enlarged nuclei, and also any abnormal chromatin, for example, if the cells are hyperchromatic or if the cells have overly coarse chromatin. And then we look in the background, always for colloid. The presence of abundant colloid favors benign nodules because abundant colloid correlates with the presence of macrofollicles. So here is an atypical architectural picture correlating with microfollicles and a follicular neoplasm. Here is a benign architectural feature, honeycomb sheets, correlating with macrofollicles and a benign nodule. Now, it is very important to know what cytology can't diagnose. And this generally is anything that really requires histologic architectural evaluation. So, for example, anything that needs evaluation of capsular or vascular invasion, such as follicular adenoma versus carcinoma. We are only sampling the inside of the lesion, and we are not in any way sampling any part of the capsule, let alone the entire capsule, which needs to be sampled. So these will be called follicular neoplasm on FNA. We also cannot diagnose a NIFP. This will go into several indeterminate categories, usually follicular neoplasm, atypia of undetermined significance, suspicious for papillary thyroid carcinoma. But we need to look at the capsule again in order to make a definite diagnosis of NIFP. It's also very challenging to diagnose low-grade lymphoma on cytology because a lot of the time the lymphoid population itself does not look particularly high-grade or pleomorphic or worrying. So if there is a history of a recently enlarging neck mass, or if there are clinically worrying signs, or if there are too many lymphocytes, we would probably end up putting it into the atypical category, AUS, atypical lymphoid population, and we would probably recommend flow or histologic biopsy. Now, I'm going to show you a very, very quick run through of a few cases to apply the Bethesda system. And this first case, you can see, I think the picture is very familiar to you. There's a honeycomb sheet of follicular cells. This is what a colloid looks like. And sometimes it can have a cracking appearance. And again, this is abundant colloid. So this would go into the benign category. And this diagnosis is a colloid nodule. For the next case, again, I think you have seen this picture earlier. This actually shows a predominantly microfollicular architecture, little rosette-like structures, and this therefore would be called suspicious for follicular neoplasm, and the Bethesda recommendation would be lobectomy or excision. Possible outcomes would be adenomatoid or hyperplastic nodule, which is benign, a follicular adenoma, a follicular carcinoma, and even a follicular variant PTC or a NIFT-P. So this ranges from benign to malignant outcomes. And if you remember, the Bethesda risk of malignancy was about 10 to 40%. In our institution, it's about 35%. And therefore, the recommendations are to excise, or as I mentioned, molecular testing. The next case is a 54-year-old lady with a left thyroid swelling, and what we see here is a mixture of microfollicles as well as flat sheets. And so it's quite difficult to decide because there seems to be two patterns equally mixed. This would fall into the atypical category or category 3, that of a follicular lesion of undetermined significance, because we can't decide if we are looking at a hyperplastic nodule or a follicular neoplasm. So in this category, the risk of malignancy is about 10 to 30% in the Bethesda system. It is useful to note that the presence of nuclear atypia generally is associated with a higher risk of malignancy than if there is just architectural atypia alone. In our institution, if there is architectural atypia, the risk of malignancy is about 15%. If there is nuclear atypia, the risk of malignancy is about 37%, so it's much, much higher. And the overall risk of malignancy is about 27%. So we do mention specifically whether we see nuclear atypia or not. And most of the time, the malignancy seen here is papillary thyroid carcinoma. So the management, again, is repeat FNA or consider molecular testing. And specifically in the Bethesda book, they have mentioned the Affirma rule-out test. It's also useful to note that up to 3/4 of cases, so usually the figure quoted is about 2/3 to 3/4 of cases, do end up having more definitive diagnosis on repeat FNA. So really you have to see what is the cost-benefit ratio in your institution and also, of course, the patient's preference. The next case is one which is quite interesting and challenging. There is actually a somewhat microfollicular architecture here, but if you look carefully at the nuclei, there are nuclei which are enlarged, there is pale chromatin, there are nuclear grooves, and this shows a degree of nuclear atypia even though the architecture is follicular. So here, this would be diagnosed as follicular neoplasm, but with nuclear atypia, and differential diagnosis would also include, in addition to follicular neoplasm, follicular variant PTC and also NIFT-P. Here is a higher magnification view showing nuclear pallor and nuclear grooves and oval nuclei. And indeed, this actually turned out to be a NIFT-P on histology. So here again, very quickly, is the summary of the Bethesda system. And we remember that the most challenging categories are the AUS FLAS category as well as the follicular neoplasm category. And these are the two categories in which molecular testing may be beneficial. So to end off, some take-home points. In thyroid neoplasms, we looked at the NIFP, which was previously categorized as encapsulated follicular variant papillary thyroid carcinoma without capsular or vascular invasion, and now is no longer called carcinoma or classified as malignant. For FNA, this would generally fall into the indeterminate categories. Frozen section is not recommended for follicular patterned lesions because we are not able to evaluate the capsule in its entirety. And these are the FNA categories which would generally not benefit from frozen sections, follicular neoplasms, and any diagnosis which includes a differential of follicular variant PTC or NIFP. And molecular aberrations in follicular variant PTC and NIFP, even though they have nuclear features of PTC, these are actually closer to follicular neoplasms like follicular carcinoma than to classical PTC. And for thyroid cytology, we have the 6 diagnostic categories in the Bethesda system. For this particular category of FLAS or AUS, nuclear atypia confers a higher risk of malignancy than architectural atypia alone, so it is important to look in the pathology report for this. Cytology cannot diagnose follicular adenoma or carcinoma because we are not able to evaluate for capsular or vascular invasion. We also cannot diagnose NIFP, again similarly, because the diagnosis requires evaluation for capsular or vascular invasion. So it's important to know the limitations of cytology. Thank you.